I give special thanks to Dr. Jeff Weiss for staying long time online. So it's time to discuss all three lectures. So please feel free give questions.
Dr. Jeffrey, can you hear me?
We cannot hear you.
Yes, I can hear you.
Okay.
Thank you for the excellent presentation. As you know well, because of low bleeding risk compared with the DOAC, factor 11A inhibitor may play a more important role than DOACs. In some coronary artery disease patients, such as high bleeding risk or especially East Asian people, would you tell us your opinion or future perspective?
Yeah, I think you heard the two talks after mine stressing the importance of balancing the bleeding risk after PCI with the risk of ischemic events and tailoring the antiplatelet regimen accordingly. And why do we do this? It's because, as was said, the risk of bleeding and the mortality associated with that is parallel to the risk of recurrent MI. So both are competing outcomes, and one can counteract the other. So if we can better suppress coagulation at the site of plaque disruption with dual pathway inhibition with antiplatelet agents plus an anticoagulant, then, and we can do it more safely than we saw with Compass or Atlas, then we may get around this problem with the balance. And we can not need to give more potent antiplatelet agents, perhaps because no matter which antiplatelet strategy we use, we still don't suppress thrombin generation. So for those who are at high risk for ischemia, it may be better to use dual pathway inhibition than to use even a potent P2Y12 inhibitor with or without aspirin.
Dr. Jeff, I think in terms of the role of factor 11A inhibitor in CAD patients, we need to wait more the result ongoing the clinical trials, because most factor 11A inhibitor trials focused on the AFib or venous thrombosis, something like that. We need more data. Okay, my question is that about factor 11A inhibitor in ESRD patient and this treatment disease patients. ESRD patients has higher ischemic and bleeding risk simultaneously. However, in many DOAC or NOAC trials, ESRD patients were excluded. So now the NOAC or DOAC has not indication for ESRD patients. Now my question is that how is the factor 11A inhibitor in ESRD patients? Is it effective or safe in ESRD?
Well, I think, as you said earlier, we don't know yet, right? We don't know how a factor 11 inhibitor is going to work in the setting of either ACS or secondary stroke prevention in non-cardioembolic stroke, where we're giving it on top of antiplatelet therapy. That's the purpose of these two trials. But we know that from the DOACs, like the elder care, for example, in patients with atrial fibrillation, even a low dose of edoxaban was better than placebo for prevention of stroke. Now, will the same thing be true with a factor 11 inhibitor, where we don't have to worry about the low dosing because it's safer? I think we do have to worry about the low dosing when we're giving on top of antiplatelet therapy. That's why for the milvexian Librexia program, the dose of milvexian that was chosen to be used on top of antiplatelet therapy is 25 milligrams twice a day, whereas the dose of milvexian go head-to-head with apixaban is 4-fold higher at 100 milligrams twice a day. You need a higher dose when you're going head-to-head with an active comparator than when you're going on top of antiplatelet therapy to use for dual pathway inhibition. So less might be more in that setting.
Thank you, Dr. Jeff. I really appreciate your wonderful lecture. My question is, I'm totally agree with your comment for the high level of thrombin generations in ACS patient. But to maximize the clinical benefit of anticoagulation use in ACS is to find the realistic high thrombogenic milieu in ACS patient. So do you have any idea to select the high thrombogenic milieu patient using assays or some scoring system? Do you have any ideas and any data?
The idea would be in the Librexia ACS study, the study is being enriched with clinical and angiographic criteria to try and select the ACS patient who's at risk for recurrent ischemic events. And some of these patients, of course, are also going to be at risk for bleeding because they're getting different antiplatelet strategies, mostly dual antiplatelet therapy, at least to start. So I agree it would be nice to have a bedside test like the Verify Now, for example, where we could identify those who have elevated thrombin generation and target those patients. But we don't have that. But I think in general, what we're learning is that it's not the index event that's the problem with recurrent ischemic events. It's the fact that we treat the index event, or you treat the index event as cardiologists, with PCI and stents and so on, and the stents are better and the techniques are better, but there are other lesions in the coronaries or in other vessels that are prone to disruption, and that triggers disruption and thrombin generation and recurrent events. So it's not just the index event, it's all the other abnormal vessels that are causing the problem.
Thank you.
Dr. White, I have two questions actually. One question is that from the practical standpoint, many cardiologists still think that the aspirin plus potent P2Y12 inhibitors, prasugrel, ticagrelor, are enough for treating ACS patients. So when we think about adding factor 11A inhibitor on top of that, we need to persuade the patient that it will do much better than just using that. So this is my first question. Do you have any idea of?
No, I think you raise a very important point, and I think it's the fact of adding on is even a barrier to the use of the low-dose rivaroxaban regimen in patients who had prior CAD, and trying to get them to switch from single antiplatelet therapy to antiplatelet therapy plus rivaroxaban is difficult. But I think the beauty of the Librexia ACS design, we don't know the results, but the beauty is it lets the cardiologist pick the antiplatelet strategy that they want. They can take a prolonged course of DAPT with or without de-escalation in the potency. They can take a shorter course of DAPT, or they can choose to use single antiplatelet right from the get-go, even if that single antiplatelet agent is a P2Y12 inhibitor, as was mentioned in some of the strategies. So this will be looked at against placebo in all those different strategies. And it's interesting, we're early on in the trial, but I would have thought, based on the second two presentations, that more of the patients entered in this trial would have the shorter courses of DAPT and either go on to single antiplatelet therapy with a P2Y12 inhibitor or maybe de-escalation. But it turns out, so far, most of the patients going into the trial are getting extended DAP. Now, that might be because, you know, clinicians are choosing the lower risk patients, even though we tried to enrich. But I think as they get more comfortable, we're hoping that they will choose different strategies so that we can see how factor 11A inhibition fares on top of any of the strategies that you mentioned.
Okay. Another question is that you know that the Asundexian ACS trial, Pacific AMI trial, had shown negative result to many practitioners because it doesn't have any effects on the efficacy and safety. So, what do you expect the Librexia ACS trial can show? And
Right.
do you have any idea on the differences in designs and etc.?
Yeah, look, the problem with the Pacific AMI trial is the size. I mean, if it was a small phase 2 study, we know from the Atlas ACS phase 2 study, they had about 4,000 patients in that study alone. You need to have a large trial in ACS patients to begin to see any efficacy. So I think that the trial just underpowered to show any efficacy. It certainly confirmed the safety of the use of asundexian on top of very potent antiplatelet therapy, because most of the patients were getting a potent P2Y12 inhibitor plus aspirin, mostly ticagrelor.
Can I question other presenter, Byung Hwang? Yeah, thank you for your nice presentation. You
Thank
and
you.
Chanjun Kim shown us the bunch of data about the de-escalation and switching trial showed a better clinical outcome compared with the standard depth therapy. So I agree with this trial result, and guidelines show us it is time for the optimal duration for the depth trial before the de-escalation. So, however, most of trial classified just clinical diagnosis. So I agree with your lesion complexity or procedural risk factor. It deeply affect to the depth duration. So my question is simple. You showed us the Prado chip trial. Do you have any data about the clinical, not only clinical situation, but also lesion procedural factor? For example, IVUS use or procedural time that affect the depth duration?
황병희 선생님 그냥 한글로 하셔도 될 것 같습니다. 답변은. 예.
아니 너무 정확한 질문이셔서 아직 분석은 안 해봤는데요. 아까 이렇게 쭉 나와 있는 거 보시면 저희가 그 컴플렉스 PCI 그거를 다 분류를 해놨기 때문에 그리고 아이브스 본 것도 다 분류했기 때문에 나중에 분석해 보면 아주 재밌는 결과가 나올 거라고 생각을 하고요. 지금은 아직 분석해 본 거는 아직은 그렇게까지는 없습니다.
보통 이제 저희가 시술할 때 칩이라도 아이브스 보고 자기가 자신 있겠다면 뭐 뎁트를 뭐 정확히 끊고 그다음에 스터디 인롤 됐으면 거기 하는데 보통 아이브스를 안 보거나 아니면 조금 걱정된다면 그냥 길게 쓰거든요. 스마트 초이스 트라이에서도 12개월 이상 썼을 때 뭐 크게 나쁜 건 없었기 때문에 그런 경향이 보통 리얼월드 프랙티스라서 그래서 이게 리전 컴플렉시티나 아니면 프로시저럴 팩터가 되게 영향을 미칠 것 같아서 선생님 그 장기욱 교수님의 스터디긴 하지만 선생님 스터디랑 그런 것들의 결과 참 기대됩니다. 예.
네, 감사합니다. 정확한 지적이신 것 같습니다.
황병희 선생님 나오셨는데요. 그 프라스구렐은 그러면 우리 프라스구렐 MI 때 쓰는 인디케이션하고 똑같은 환자만 인롤이 되나요? 어떻게 되나요?
네, ACS에 딱 그 보험 기준에 맞는 사람만 지금은 현재 인후를 하고 있습니다. 안 그러면 다른 방법이 없어서요. 네.
두 교수님한테 한번 여쭤보고 싶은데 펀더멘탈한 일 여쭤보고 싶은데 이제 아까 뭐 김찬우 교수님도 얘기하셨는데 뭐 한국 사람이 하이 블리딩 리스크, 로우 이스케믹 이벤트라면서요. 근데 우리가 쓰는 그런 크라이테리아 있잖아요. 뭐 HBR 크라이테리아, 그다음에 뭐 하이 이스케믹 리스크에 대한 크라이테리아가 그게 다르지 않잖아요, 사실은. 그죠? 서양 쪽이나 뭐 동양 쪽 데이터랑 그게 다르지 않은데, 그러면 그거 어떻게 설명하실 건지, 뭔가 지금 크라이테리아 이슈가 뭐 한계성이 있는 건지 갑자기 그런 거 여쭤보고 싶어서 김찬우 교수님. 이거 똑같은 거 쓰고 있잖아요. 칩도 마찬가지고 다 똑같은 거 쓰고 있는데 다르다고 얘기하니까 이게 설명이 잘 안 될 것 같다는 생각이 들어서.
그래서 사실은 똑같은 걸 쓰고 있어서 우리나라 메이저 페이퍼에 퍼블리케이션이 되는 거거든요.
그 교수님도 이제 한번 언급을 하신 적이 있지만 이제 그게 정말 이제 RCT로 증명이 된 건 아니지만 그 이스트 에이시안 패러독스라는 그런 개념이 사실은 그 유령이라고 해야 될지 아니면 계속 이제 적어도 이제 그 가이드라인이나 아니면 리뷰나 그런 저널에서 보면 꼭 그런 얘기가 나오고 있습니다. 그래서 정확하게 레퍼런스에 대한 언급을 하지는 않지만 꼭 그 이스트 에이시안 패러독스에 대한 언급이 있고요. 그리고 또 한 가지는 사실은 그 동안에 이런 트라이얼을 평가하는 그런 리뷰나 아니면은 비어 포인트 같은 거를 이제 좀 보면은 한 가지씩 언급하는 게 저희가 말씀드린 호스트 RPCS나 아니면 있고 저희 그리고 탈로스 MI 트라이얼 같은 경우는 모두 이스케믹 엔드 포인트에서 항상 로우 파워가 나옵니다. 예상했던 것보다 이벤트가 적었기 때문에 그게 로우 파워가 되고 그렇기 때문에 실제적으로 이거를 모두 다 가이드라인을 몽땅 적용을 해가지고 그때 웨스트 코케이시안들한테 적용하기에 좀 주저하는 그런 경향이 있는 것으로 생각이 되고요. 그리고 그런 의미에서 제 생각에도 꼭 한 가지씩 코멘트가 나오는 게 이제 서양에서도 그 내처 메디슨 리뷰에서 한번 나온 얘기긴 한데 앞으로 나와야 될 새로운 클리니컬 트라이얼들이 과연 이스테이션에서 나오는 클리니컬 데이터보다 더 로버스트한 데이터가 이제 필요하다 그런 코멘트가 있었습니다. 그래서 제 생각에는 이런 우리 아직도 이스테이션하고 이제 웨스턴하고 이제 다르다고 여겨지고 있는 이유는 결국은 이제 클리니컬 트라이얼의 언더파워 그리고 과거에 있었던 이제 이스턴 에이시안 파라독스라는 그런 개념이 아직도 이제 자리 잡고 있기 때문이라고 저는 생각합니다.
제프 선생님한테 한번 물어볼까요? Dr. Jeff? Dr. Jeff Weiss, are you there?
Yes, I am. I'm here.
Sorry for Korean discussion. We are talking about East Asian paradox. So East Asian people have low risk of low ischemic risk and higher bleeding risk. But the now world is rapidly becoming one. So what do you think about East Asian paradox? Is real existence or just the diet or lifestyle contribute to East Asian paradox?
You mean the risk of the ischemic risk, the difference in ischemic risk in different populations? Is that what you're getting at? Yeah, well, for example, we used to think that the people in Japan had a lower risk of venous thrombosis until we did studies in Japan in patients undergoing knee replacement surgery and found that the first studies with edoxaban were done against placebo because there was no standard of care anticoagulation that was given to those patients because the risk of thrombosis was thought to be so low. But when venograms were done, it turned out that in the placebo group, the risk of DVT was about 48%. So I don't think they are protected. So, I don't know. It could be diet, of course, and the question is what happens if you have an atherosclerotic plaque rupture and what happens to atherosclerosis and what is the inflammatory component? All of those, I think, we don't understand properly in terms of the racial impacts on those types of events.
Okay, thanks. It's a lot of time. After listening three topics, I expect next antithrombotic issues in our field is the factor 10A inhibition into our clinic, and second is potent p12 inhibitor monotherapy after acute chronic syndrome. So I appreciate Dr. Jeff Weiss for your contribution of this symposium. We hope seeing and listening to your lecture in the coming symposium. Thank you for
Thank
all.
you very much, and I hope we can do that in person the next time.
Okay. Yeah. Thank you for all speakers and panels. So it's time. I'd like to close this session. Thank you.